Thank you. So currently, 340B discounts are provided at the point of purchase. However, pharmaceutical manufacturers have tried to implement rebate models in the program, and the Health Resources and Services Administration has proposed a rebate model pilot program that would go into effect on January 1st. I've heard from hospitals and community health centers across Wisconsin that a rebate model would be disruptive to their finances and threaten their ability to continue to provide their current level of care and services. One community health center in Wisconsin has said that under the proposed pilot program, their upfront drug costs would increase by 2,360%. Threatening their financial stability and, of course, patient care. I've heard similar concerns from hospitals, particularly from rural hospitals, and that they would struggle with millions more in additional upfront costs under a pilot program as proposed. Dr. Feldman, how would a rebate model change the operation of the 340B program, and what would the impact of this shift be on providers and on patients?
The way that 340B discounts currently work, imagine you have a drug that costs $1,000 with a 70% discount. A 340B hospital would pay $300 for the drug upfront. The way that a 340B rebate model would work is the hospital would pay $1,000 upfront and then get back $700 later. I worry about this model for a couple of reasons. One, as you pointed out, is that some institutions may not have the cash to make that payment upfront. And then the second is that it puts the pharmaceutical industry in control of determining which rebates to give. So I would much prefer to see a solution like a third-party clearinghouse that is helping to resolve the discounts that are being given.
Okay, thank you. Some have criticized the 340B program for lack of transparency, including how program savings are used to benefit patients and communities. Many have also said that HRSA has insufficient resources to provide oversight of both manufacturers and covered entities. So I believe that we need to increase transparency within the 340B program while ensuring that there's not an undue administrative burden. Ms. Rosenberg, what concerns about transparency and ability to provide oversight has the GAO identified?
So as you noted, there aren't requirements for entities to specify how they use the revenue from the 340B program, what it's towards. There's also been questions about whether they pass on discounts to patients, which is not required by the statute, but there's not information in terms of that. HRSA also doesn't have good insight into things like whether the entities meet the eligibility requirements. Non-governmental hospitals are eligible for the program if they meet a certain DISH metric. That is something that HRSA checks, but they also have to have a contract with the state or local government to provide services to low-income individuals who are not eligible for Medicare or Medicaid. And HRSA has not reviewed all of the hospitals to see if they actually have such a contract. And when we looked at a sample of them, we found that not all of the hospitals did.
Thank you. And look, hospitals, community centers, and other safety net providers are really staring down the barrel of the Medicaid cuts and the undermining of the Affordable Care Act, including by ending the tax credits. So I think 340B will only become more essential to preventing hospital and clinic closures and ensuring patients have the access they need to health care. Dr. Feldman, please briefly explain why 340B is essential to those types of providers.
I agree with you that as we see more cuts to Medicaid, more patients without insurance, we are only going to see more strain on community health centers and other 340B covered entities because they will find themselves providing more uncompensated care.